Good evening, everyone. So, this week again, we're going to continue our discussion on venereal diseases. And last week, we had a discussion on primary syphilis, and this week we'll continue with secondary syphilis. Now, syphilis is an important disease for the postgraduate, for specifically and generally for every venereologist and dermatologist. And the issue with syphilis is that we usually regard it as only a genital ulcer disease because that's when we usually suspect syphilis, especially in our early practicing years. But we have to remember and realize that syphilis is actually a systemic disease from the onset, from the very first chancre that develops on the genitalia. The syphilis is a disorder that is going to affect all other organs in the body if the treatment is not given on time. That is why it becomes very important for us to recognize syphilis so that we can treat it properly, and we can also handle if any kind of complications occur because of treatment, without treatment, or any other organ involvement occurs because of the widespread infection by Treponema pallidum. So that being said, let's start a discussion on secondary syphilis this week. Now, just a little bit about history. Usually, syphilis was a disease seen in the New World. Okay, that is, and when we say New World, we mean Americas. Okay, the North America, South America continents. And it has been postulated that the pre-Columbian syphilis, and here the Columbian means the Great Columbian Exchange. That means, what do we mean by a Great Columbian Exchange? Is that when Christopher Columbus reached North America, after him reaching the Americas, there was a significant exchange of goods, commodities, and slaves between the European continent and the American continent, and that was essentially known as Columbian Exchange. Another important and albeit a very important aspect of Columbian Exchange was the exchange of microorganisms and the exchange of diseases. And that is why syphilis becomes one of the major aspects of that Columbian exchange, the microbial Columbian exchange. So that led to post-Columbian syphilis. That means when syphilis as a disease traveled from America via Christopher Columbus and reached Italy. Okay, this was via Christopher Columbus. And after Italy, it spread to France, and from France, the whole of the Europe was affected by syphilis. And when we say syphilis, we are not talking about primary chancre. Remember, primary chancre heals on its own without treatment in 3, 4, 6 weeks. We are talking about secondary syphilis. We're talking about the widespread manifestation of syphilis and the involvement of each and every organ in the body. And it has, if I remember correctly, the rate of mortality in secondary syphilis, which is untreated, is roughly at about 8 to 15% because of organ failures. So that is why syphilis was known as the scourge of that time, the plague of that time, and it was very, very infectious, particularly or actually only through the venereal route. And because of that, there was significant widespread infection of syphilis in the entire Europe in those areas. And when we are talking about Columbian syphilis or the Columbian exchange, we are talking about 1400s, 1500s. And we are studying this disorder in 2020s. Why? It has remained for the last 500 years and it is causing irreparable damage. Okay. Two different studies that I would like to point out is Oslo study and Tuskegee study. And these are two of the most you can say infamous studies, unethical studies to study the syphilis, or we could say to study the progression of syphilis if the treatment is not given. And these were very unethical studies. And if you have time, go and look, search about them and read, and you will be able to understand that our major understanding about the syphilis pathogenesis comes from these two studies, which were entirely unethical. But we need to take care of knowledge wherever we can get from. Subsequently, many of the American prison had programs of inmates voluntarily giving themselves up for the scientific study of syphilis, and they had to be inoculated with syphilis so that people could learn about how syphilis actually manifests. All of these three things are unethical. With that being said, let's start the discussion on secondary syphilis. So last week we had discussed that syphilis is because of the infection by Treponema pallidum subspecies pallidum. Okay, I'm not going to go into detail about different treponems. If you want to know about them, see the first video, the primary syphilis one. Syphilis is a systemic infection from the outside. That means the moment the primary chancre is created, it is not localized to that chancre. Minimum to minimum, it's going to infect the mucosa and subsequent draining lymph nodes, causing lymphadenopathy, where the spirochetes are also found. But it has also started to infect the entire body, and it has started to go into the bloodstream now. Okay. And when the infection or when treponemes actually enter the bloodstream, it becomes a systemic infection. So even if the patient is presenting with just a primary chancre, it is quite reasonable to say that the infection has spread to the blood. Okay. So we last week we read that primary syphilis presents as a chancre which heals with or without treatment, but the patient can go into secondary stage. Now the probability of secondary stage when the treatment is not given in the primary stage is nearly 100%. That means if the primary chancre is not treated, the patient will develop inevitably sometime later secondary stage of syphilis. Okay, if the treatment is given on time, the probability decreases to very less. Patient might still develop secondary stage even after proper treatment of chancre. There can be multiple reasons for that. But if the treatment is not given, everybody develops secondary stage. There is variable presentation because nearly all organ can be affected, and we can have different kind of manifestations depending on what organ system is being affected. Okay, that is why syphilis is known as the great imitator. That because the variable presentation means that there are variable differential diagnosis of the lesions, and it can imitate a wide variety of dermatosis. That is why syphilis is known as a great imitator. This could be a quiz question. Okay. So what we are dealing now is infectious or early syphilis. Remember last week we divided syphilis into two parts, early and late. Okay. Late is non-infectious, while early is infectious, and secondary stage comes from the infectious aspect. Now what do we mean by infectious? Particularly, the rate of infection is very high from person to person in the early stage. In late stage, the rate of infection will still be present, but very, very low. So that is why it was divided into these two parts. Might not hold true currently because we know that latent syphilis can also be infectious. Okay, let's go forward. The chancre usually heals before the second stage begins, but the primary chancre can persist in about 12 to 34% of females and 56 to 63% of males. So the primary chancre actually heals first, and then the process of development of secondary stage starts. But in these population, about like 34% of females, 63% of males, the primary chancre can still be present when the patient develops a secondary rash. Secondary incubation period is the period between first is the infection, and then you have the secondary rash or the rash of secondary syphilis. This is secondary incubation period. Primary incubation period is between the infection and the primary chancre. Secondary incubation period is between the infection and the secondary rash, which is roughly about 8 weeks, but is always less than equal to 6 months. Average duration is about 3.6 months, but it can last to a year. Okay, and this is the duration of secondary rash or secondary syphilis. Okay, this is the duration of secondary syphilis. Relapses can occur in about 25% of patients. What do we mean by relapses? That means if you have a patient with secondary syphilis, you treat patients again develop secondary syphilis. Okay, so the relapses of secondary syphilis can be seen in about 25% of patients. After the secondary stage is over, after the secondary stage is over, whether it is with treatment or without treatment, the patient enters a stage which is known as a symptomatic stage. Here we call the syphilis as latent syphilis. Now, what do we mean by latent syphilis? That means the spirochetes are present in the system, the antibodies are present in the system, the serological test and all diagnostic tests, all treponemes specific tests will be positive in that time. Okay, and they might be having the patient might be having relapses, infrequent relapses in between them. And after the latency stage is over, you get tertiary syphilis. or specific syphilis like cardiosyphilis, neurosyphilis. These syphilis will develop. Okay, gummitous syphilis. A good important term that I would like to discuss now is syphilis incognito. In syphilis incognito, there is no clinical manifestations. No clinical manifestations. But the serology is positive. Okay, so there are no clinical manifestations, but the serology is positive. For example, the patient might never know that they have encountered syphilis. They either don't remember the primary stage or they have disregarded the secondary stage, and the patient have the evidence or the laboratory evidence of syphilis, but they have not developed clinical symptoms. They usually come with a positive report of a diagnostic lab test. So they don't give a history of any kind of syphilitic manifestations, but they will be carrying a test report which shows TPHA positive. Okay, so that is known as syphilis incognito or unknown syphilis. So remember, in the latent stage, the serology is positive. So what happens is that there are two distinct divisions. We have the early syphilis or the early stage and the late stage. Now remember, the late stage is different from the latent stage. In latent stage, it is asymptomatic. Okay, and the treatment also differs. For example, in early stage, let me just write it down again. In early stage, you can have the primary chancre, you can have the secondary rash also. In late stage, you have the secondary rash also, you can have latent, and then you can have tertiary syphilis. Okay. The temporal division between early and late syphilis is a bit different. For example, the CDC guidelines and the European system of guidelines say that 1 year difference is between early and late. That means if a person is infected, let's say this is the timeline and here is the infection, then after 1 year, the first year will be early syphilis and after that it will be late syphilis. Clear? However, WHO and UK has a limit set at 2 years. So what do we mean by that? That you have the infection, but after 2 years, the late period starts. Before that is the early period. Now, why is the distinction present? See, you have to understand that spirochetes divide rather slowly. The division time we have discussed in the last video. The division time is initially fast and the population is also low. So when the primary chancre is there, the absolute number of treponins would be less because it has just infected and it is trying to spread in the body. Okay. So that is why you give a single shot of penicillin. But with time, the spread is so massive and covering and occupying the entire bloodstream that now the organism, you have to use a higher doses of medications, higher duration of medications, increased frequency of medication to take care of those treponins. That is why you give 3 shots of penicillin 1 week apart, isn't it? The treponins in the late stage also divide rather slowly. So you need to give repeated treatments. That is why you have penicillin week 1, week 2, week 3. Okay. The distinction between early and late is such so that in the early syphilis, a single shot penicillin is okay, while in late syphilis, 3 shots are required 1 week apart. And that is why we need to know about the distinction between early and late so that we must know that should we give 1 shot of penicillin or 3 shots of penicillin. Okay. That is why the distinction is there. Let's move forward. During the primary chancre, the spirochetes start to stimulate the immune system, and gradually humoral and cell-mediated immunity develops. Okay, and this mediated immunity is responsible for elimination or death of the microorganisms. And when these organisms are removed from the system, you have healing of the primary stage. Okay. If the treatment is given, then that is where the train stops. But if the treatment is not given, this will proceed towards a secondary stage. What happens in secondary stage? Remember, in the primary stage, syphilis is a systemic disease at the first from day one. Okay. If the treatment is not given, that means treponins are surviving in the bloodstream, no matter if the primary chancre is healed. So that is why there are treponins present in the bloodstream, and spirochetemia, that means presence of spirochetes in the blood, occurs early, and it leads to the development of secondary stage irrespective of the primary stage. So even if the primary stage heals, it heals within a day, okay, but the spirochetes have entered the bloodstream and they will progress to form the secondary stage, okay. Many authors have called syphilis or Treponema pallidum as stealth pathogen. Why do we know? Why do we call it as a stealth pathogen? Means that if here you have the spirochete. Okay, let me just make it again. So here we have the corkscrew-shaped spirochete. If you want to learn more about the structure of the Treponema pallidum, see the first video, the primary syphilis one. Okay. Now, there are some outer membrane proteins which are very antigenic and are responsible for the development of antibodies. And this interaction of antigens and antibodies are responsible for killing the treponins. Okay. But what happens is Treponema pallidum has a coating on it. Okay. It has a coating around it that kind of hides these outer membrane protein antigens. It hides the outer membrane proteins. Now, since these outer membrane proteins are hidden, they are not exposed to the immune system. That is why it is it is not able to incite a significant immune response, and the Treponema pallidum organism survives in the bloodstream. Okay, since these antigens are hidden, it is known as stealth. Okay, it is stealthily hidden from the immune system, and the organism is known as a stealth pathogen. Am I clear about it? So let's move forward. The So there's an entity known as Trompus, I think Treponema. I'm forgetting about the R. Treponema reactive outer membrane proteins, somewhat like that. So this is a short form Tromp. Let's move forward. What actually happens is that even if the primary chancre is healed because of the immune mediated destruction of the organism, there are a few left out treponins that are going to survive, and that leads to the incomplete clearance of treponins from the body. Now, how does the organism is able to evade the immune system? There are many theories about it. I've just highlighted few of them. Okay. First is immune cell apoptosis. So there are multiple interactions, namely the fast ligand interaction among the immune cells, that propels the immune cells towards apoptosis. Now what happens is that because of fast ligand fast interaction, and we have discussed that previously in our videos on pathogenesis of psoriasis, that this fast ligand interaction initiates the process of apoptosis, and the spirochetes somehow trigger this mechanism so that these immune cells die early and are cleared from system. So it's like you have a criminal and the police is trying to catch it, and the criminal is doing something so that the police is not able to even leave the police station or even reach the criminal. The second is the Treponema pallidum does not have lipopolysaccharide. What do we mean by that? Now, lipopolysaccharide is a very important antigen molecule. In many of the organisms, namely bacteria, lipopolysaccharide is responsible for the antigenic modulation or the development of antibodies. Treponema does not have a lipopolysaccharide coat, and because of that, the antigen-antibody interactions are not proper in Treponema. And we have talked about the third, which is hidden antigenic outer membrane proteins. We have talked that the coating actually hides the outer membrane proteins which are responsible for the antigen antibody interactions. And these all, and there are multiple theories. If you want to go in details, I'll put the link of this article in the description box, and you can go ahead and read the full article. It will tell you about various mechanisms by which the Treponema pallidum actually evades our immune system. Okay, so let's move forward. So we have discussed that the primary chancre heals and then the secondary stage kind of starts, and irrespective of the outcome of the primary stage, the patient will develop a secondary stage in the future. In clinical features of the secondary stage, remember the secondary stage is a generalized disease. Okay? It's a generalized disease. That means each and every organ is at stake. It can involve any organ. So any of the organ of the body can be involved by syphilis and can present as any varied presentation. The skin rash is the most common feature along with lymphadenopathy. So skin rash is seen in about 67 to 92%, and it is the presenting feature of secondary stage. Now, what do we mean by presenting feature? That means it is a feature most commonly the patient will come to us with. They will come to us with a lichen rash, okay, or any kind of different morphologically different rashes. And then you have to keep syphilis in your mind. Now, lymphadenopathy is in about 63 to 100% of patients. So these two become the most common clinical manifestation. And out of these two, the rash is the most common one and the most common feature with which the patient will come to us. Along with that, there is flu-like prodrome consisting of fever, malaise, headache, stiff neck, myalgia, arthralgia, non-specific body pains. These are all described by the patients in the secondary stage. Let's move forward. So as we have said that rash is the most common one, okay, and it is the most common presenting feature also. So we need to know a bit more about the rash presenting feature. Now rash can have a varied morphology. It can range from macular to papular to maculopapular, papulosquamous, psoriasiform, annular, pustular, follicular, lenticular, corymbose, annular. I think I've repeated it. Annular. Now, the most common morphology is actually macular or maculopapular, which is seen in about 50% of cases. Okay, roughly about 50% of cases they present as a macular eruption or a maculopapular eruption. Each of the lesion has been described as a raw ham or a copper colored macules, but they are mostly seen in the white population or people with lighter skin tone. In pigmented skin tone or highly pigmented skin tone, or we could say the Indian subcontinent, the lesions can be darker color with a purplish hue. Purplish hue. Purple like this. Okay, so purplish hue. It is bilaterally symmetrical. At the onset, the rash of secondary syphilis is bilaterally symmetrical, but if the relapses occur, then the rash may be asymmetrical. Okay, it may be asymmetrical during relapses. The rash is non-pruritic, but in 8 to 42% of the cases, it can present with itching and mostly the follicular morphology of rash. That means the follicular syphilitic rash is the one associated with itching. Okay, so I've described it that the most common presenting morphology of the rash of syphilis is macular or maculopapular, seen in 50% of the cases, and it presents as a raw ham or a copper colored macules, symmetrical macules. These are some terms which are specific for the syphilitic rash, and we'll go through them one by one. One is roseola syphilitica. These are 0.5 to 2 centimeter pink, discrete, round to oval macules over the trunk, flexor, palms, and soles. So these are the descriptive term given to the lesions of rash of syphilis. Okay, this is first, roseola syphilitica. Second is corona veneris, or the crown of venereal diseases. Okay, so these are papules along the hairline on the forehead in a crown-like pattern. So if the head is here, you will see the papules clustered around the hairline. Okay, clustered around the hairline, and this is corona veneris, or the crown, in a crown-like fashion. Third is Buschke-Ollendorff sign. I think there's supposed to be two dots here. Yeah, Buschke-Ollendorff sign. This is the sign in which there is deep dermal tenderness elicited by applying pressure with the blunt side of a pin over a papule. Now, what do I mean by that? If there is a rash and you have a pin, remember it's an upside down pin, not the pointed end. Otherwise, you will face legal actions from the patient. Okay. Just push it with the blunt end and it will elicit a painful response. This is known as Buschke-Ollendorff sign, and this is pathognomic of secondary syphilitic rash. So if you see any kind of rash which is tender on blunt palpation with a pinhead, consider syphilis. Okay, secondary syphilitic rash. Now there have been hypotheses about the reasons why it is deep dermal tenderness, but mostly it is because of the involvement of the deep dermal vessels. So vasculitic like inflammation has been mentioned as a reason for Buschke-Ollendorff sign. Fourth is Leucoderma syphiliticum or coli, Leucoderma coli, or necklace or collar of Venus. Coli is collar. Okay, so Leucoderma syphiliticum. Leuco is white, derma is skin, syphiliticum. So white skin in syphilis. So these are depigmented macules around the neck after the resolution of rash. So when the rash resolves, it leaves behind these kind of depigmented macules around the trunk like a necklace, and that is known as necklace of Venus or collar of Venus or Leucoderma syphiliticum. When syphilis involves hair, it can present as a follicular rash, which can eventually the inflammation can lead to alopecia. Okay, it may present as irregular, non-scarring patchy alopecia, which is described as moth-eaten alopecia. So, what do we mean by that? So, this is the scalp. This is the top view of the scalp, and in fact, in the top view of the scalp, let me just remove these lesions. Yeah. So, in the top view of the scalp, you will see this irregular, patchy loss of hair. Okay, so this patchy loss of hair is described as moth-eaten alopecia. It can also present as telogen effluvium if it involves somewhat of a diffuse area rather than being patchy. The nails show pitting, onycholysis, onychodystrophy, and bruised lines. So we know what the bruised lines are. These are transient interruption in the growth of the nail. It presents as transverse ridges, okay, on the nail plate. So bruised lines. So here are some examples. Here are some examples regarding the rash of syphilis. So here you can see this kind of copper colored macules. Let me just change the color. Yeah. So can you see this kind of copper colored, somewhat like brownish, dusty erythematous rash? Look at here. Okay. This is a rash of secondary syphilis. This I've taken from a textbook. Okay. So secondary syphilitic rash. This is an old human model, if I'm not wrong. And here you can see the papules. So can you see this papules? So this papules is corona veneris. Corona veneris. And here you can see non-scarring alopecia, which is moth-eaten alopecia. So we are clear about some of the systemic manifestation. So whenever a disease has a lot of different variable presentation, a best idea is to remember those manifestations from head to toe. So from the hair, you have the moth-eaten alopecia, then corona veneris, then you have the syphilitic rash over the arms, trunk. You have the collar of Venus on your trunk. You have the roseola syphiliticum over the body. Okay, so just remember them from top to bottom. It will be easier for you to remember. Another specific morphology in secondary syphilis is Condylomata lata. Okay, so it's a long name to pronounce. I'll mention it as C lata now. Okay, so Condylomata lata is a bit of a specific morphology of lesions in secondary syphilis. C lata is seen in about 25 to 60% of the patients. And what exactly is C lata? It occurs in warm and moist areas and involves, for example, areas like genitals, perineum, perianal region, inframammary region, axilla, groin, areas which are more susceptible to humid, moist environment. Okay. Morphologically, it presents as pale, elevated, moist, sharply demarcated papules with flat surfaces. So somewhat like this in cross section. Okay. And this will be moist. Moist. Okay, so moist raised papules with flat surfaces. C. lata is highly infectious. What do we mean by highly infectious? That means it is filled or teeming with treponins. So if that comes into contact with another person where the skin is broken, you might have theoretically transfer of treponins and infectivity of syphilis. So C. lata lesions or C. lata papules are very infectious. If they occur around the labial commissures, for example, let me remove this. If C. lata type papules are present at the corner, let's say corner of the lips or at the nasolabial folds, these are known as split papules. Okay, split papules. Clear? So these are some terminologies and some discussion about C. lata. So if you can see here, let me just change the color. Yeah, if you can see here, these papules on the penile shaft, they are flat. They have risen papules which have flat surface with moist looking appearance. So this is the morphological appearance of ciliata. Now they can arise as this kind of a fleshy verrucous, not exactly verrucous, but a fleshy collection of papules. Now, this is a photograph taken by me in one of my patients, and this on histology came out to be C. lata. So, in moist area, you can see the background moistness is present. This was at the left inguinal fold. Okay, so you can see this kind of lesions in the moist area or fold areas of the body, like the inguinal fold. The involvement of the mucous membrane inevitably is very common in about 4 to 17%. Mucous membrane lesions are very infectious. So lesions occurring on the mouth, oral mucosa, genital mucosas, these are very infectious. They can present either as an asymptomatic papule or oropharyngitis or involvement of the pharynx. In fact, upper esophageal involvement has been described in literature. They can also present as serpiginous ulcers. That means ulcers which are undulating like this, and these are known as snail track ulcers. Like the tracks when snails move on the ground, the track that they leave is known as snail track ulcers. Now, they are mostly superficial erosions, papules, and plaques, and there have been case reports of mucosal syphilis presenting or resembling oral hairy leukoplakia. So, the case reports of oral hairy leukoplakia are present, and it usually presents as superficial erosions, and they can have that undulating character known as snail track ulcers in the mucous membrane. So, here we can see involvement of the mucosa, the superficial erosions, mucosa. In fact, in this patient, the gums are also involved. And look at this raised flat area, somewhat slightly verrucous. And this is the same image of C. lata, because C. lata can also occur on the mucosal surfaces. So we have discussed the cutaneous manifestation. We have discussed the rash. We have discussed other types of morphologies like C. lata. We have split papules. We have discussed the mucous membrane involvement. Now we'll discuss about the systemic manifestation of secondary syphilis, because remember, it's a systemic disease from the first day. Now, malaise has been reported, low-grade fever, iritis, uveitis, arthritis, parotid gland inflammation, pulmonary involvement, all have been reported. In CNS infection, it could be asymptomatic, but 25% of the treponemes, 1/4 of the treponemes will show invasion into the CSF area or in the subarachnoid space. It usually presents as CSF leukocytosis and decreased protein. Okay, not decrease, but increase. Let me say it again. It presents as CSF leukocytosis and increased protein, and the CSF VDRL will be positive. So even if the serum VDRL is negative, if a person has invasion of CSF, the CSF VDRL will be positive. 1/3 of the patient complained of diffuse headache when there is involvement of the CNS in syphilis. In gastrointestinal system, you have anorexia, nausea, occasional vomiting, mucosal erosions have been described, rugal hypertrophy can be seen in stomach. In fact, stomach, specifically the antral and the pyloric area, can show shallow ulcers. So if you have the stomach, so the antral and the pyloric area can show shallow ulcers. And remember, shallow ulcers are mostly seen on mucosa. So the gastric mucosa can be inflamed and red, showing shallow ulcers. Hepatosplenomegaly is seen in about 4 to 23%, 4% to 1/4. Jaundice can be seen in about 12%. There is weight pain, arthralgia, and periostitis is a rare manifestation, about 0.2%, but bone involvement can still be there. Now, remember in the history part in 1400s, 1500, bone involvement was actually quite common. Okay, so bone involvement was actually quite common, and lytic lesions of the bones have been described. In fact, the pre-Columbian syphilis was actually a term given in the older when archaeologists examined the bones found at the excavation sites. They found that the bones were showing lytic lesions similarly seen in patients of syphilis. And that is why they gave the term that syphilis might be a disease which has been occurring for a very, very long time and not only limited to the limited after the Columbian exchange. Okay, kidneys can be involved, although rare, but can present as asymptomatic proteinuria or rapidly progressive glomerulonephritis and can have frank renal failure. So that is also described. In cardiovascular system, you have features of myocarditis and ventricular arrhythmia. These are separate from the features of cardiosyphilis that we usually see in the tertiary stage. Okay, these are the heart manifestation in secondary syphilis. Lymphadenopathy is seen in 60 to 100%, and lymph nodes are rubbery, painless, discrete, non-tender. Okay, so remember that what actually happens in the pathomechanism of syphilis is that first the mucosa gets inflamed, then the lymphatics, lymph nodes, blood, and then each and every organ is at risk of developing this kind of manifestations. Now, Lues maligna. Lues maligna is an important concept. Usually, it is usually asked in vivas, or you may be asked in your paper 3, write a short note on Lues maligna. Now, Lues is an older term for syphilis. When we say older terms means before the disease was characterized as syphilis, it was known as Lues. Okay, so Lues maligna is another term for malignant secondary syphilis. It was described by Bazin and Dubé in 1800s as an explosive widespread form of syphilis. So you have an explosive widespread, you could say severe form of syphilis. It presents as fever, headache, myalgia, photophobia, then gradually goes towards papillopustular eruption, and those eruptions then gradually increase to form necrotic, sharply marginated ulcers with erythematous halo and hemorrhagic brown crust in rupeoid layers. These are known as oyster shell crusts. Now let me reiterate what I'm saying. In Lues maligna, either because of immunodeficiency or host or agent-specific mechanisms, there is widespread destructive form or explosive form of syphilis. In this form, there's a generalized eruption in the body, and gradually there's development of multiple necrotic, sharply marginated ulcers. That means the margin would be distinct. It will have an erythematous halo because of severe inflammation which is going on, and there will be necrosis inside because again there is severe inflammatory damage which is occurring, and development of a hemorrhagic, that means blood filled brown crust in thick layers. That's what we mean by rupeoid like limpet shell like thick layer crusting. A thick brown crust will be formed on top of them. and those crusts are known as oyster shell crust. Maybe as hard, and the appearance also looks like a laminated appearance of oyster shells. Lues maligna is about 60 times more common in patients who are seropositive for HIV. Again, immunodeficiency. So it is 60 times more common in immunodeficient patients. So here we can see the manifestation of Lues maligna, again taken from a textbook. So look at the lesions here. These are all crust, brown crust, and they are very sharply demarcated. Okay, these are sharply demarcated, and look at them that they have an erythematous halo around it. Okay, so these are the Lues maligna crusting. Similar on the genitalia, we can see the crust, and these are the crust from a somewhat of a magnified view, and these are the brown. You can see the brownish color here, brownish dark oyster shell like crusting or oyster shell ulcers. So these are the oyster shell crust or ulcers. Let's move forward. Okay, so relapse. Okay, one thing I would like to add in Lues maligna, that there can also be widespread tender lymphadenopathy, and the most specific group of lymph node, most specific, is the epitrochlear group of lymph node just below, just behind the elbow. If those groups are involved, it is very specific for syphilis. Okay. Now relapse. I've told you that relapse can occur in about 25% of the cases, and it can happen after several weeks to a year. Usually occurs in the first year, but when the duration is increased, the rate of relapse also increases. So about 20 to 25% of patients will have a relapse. Now, how can we term a disease as a relapse and not a reinfection? So let's say if person comes with primary syphilis, you treat the infection, then develops secondary syphilis, you treat the infection, then again comes after 6 to 9 months that I've again developed the rash. Is that a relapse or a reinfection by syphilis? So there are some pointers about it. For example, infection of a sexual partner after an apparent cure. So for example, you treat your patient and in their partner, primary syphilis develops. So this could be a chance. This could be a pointer towards a relapse. Okay. Or you see, in all cases of relapse, you have to check for HIV and also look at the CSF VDRL or CSF TPHA to see whether the disease or the treponins is not surviving in the CSF segment. Remember, penicillin does not have a good blood-brain barrier penetration, so there might be a chance that treponins can survive in the CSF. So we need to examine that if the patient is having relapses. Now, relapses, I've told you before that it could be asymmetrical. Let me write it again. Asymmetrical. Now, the rash of syphilis is symmetrical, but in the case of a relapsed syphilitic rash, it can be asymmetrical. The severity is less. Severity is less, and asymmetrical severity less. The prodrome is less. The prodrome or fever, myalgia, it's not that severe as the first episode of a secondary rash. Okay. What is transplacental relapse? Transplacental relapse is birth of a child with syphilis to an apparently cured mother. For example, the mother has been treated for syphilis, cured or apparently cured because the tests are showing negativity, but now the child born to that mother shows active syphilis. Okay, so birth of a child with syphilis to an apparently cured mother is known as transplacental or through the placenta relapse, transplacental relapse. Let's go forward. There are certain variants, majorly morphological variants of the rash of syphilis. For example, lichenoid syphilis, in which you have the violaceous hue, mostly seen in pre-penicillin era, but now it has been increasingly seen with after the HIV epidemic. Annular syphilis, usually seen in African Americans, involves the face, anogenital area, axilla, palms, and soles. Now, one thing to remember is that the rash, the normal maculopapular rash of syphilis spares the face, or let's say no, mostly spares the face. So face can be involved, but it is very rare. In annular syphilis, face is usually involved. In lenticular syphilis, the lesions are pinhead or lentil, for example, pulses, the normal dal that we have at home. Lentil bean-sized papules on the face and genitalia. Again, the face is involved in lenticular syphilis. Corimbos or bombshell-like eruptions. In Corimbos syphilitic rash, you have a central large plaque, and then you have surrounding small satellite papules. It is also very rare, usually seen in later stages of secondary syphilis. Now, if you remember, not you won't remember, but in botany, Corimbos is a type of inflorescence. That means how the flowers uh, flowers are present on the stem. Okay. And in Corimbos, the flowers reach the same level as the topmost flower, like this. And if you look from top, it will present as a single large plaque with surrounding small plaque. So that is why this is the Corimbos type of eruption in syphilitic rashes. The differential diagnosis of rash is multiple. It can be infectious like rubella, measles, or non-infection like drug rash. If the rash are significantly scaled and crusted, it can mimic psoriasis, pityriasis rosea, in fact, lichen planus, because they have a lichenoid hue. They also have a lesional erythema. So these kind of differentials are present. That is why we call secondary syphilis as protean or the great imitator. Okay. It can even the prodrome can mimic the HIV seroconversion illness that is also present. The lesions of nodular syphilis can mimic deep mycosis, leprosy, tuberculosis, sarcoidosis, lymphoma. So these are the differential diagnoses of secondary syphilitic rash. Okay. So we have discussed the agent in the last week's video. Now we have discussed the presentation in secondary syphilis, mainly the rash in detail, C Lata, extragenital manifestations, cutaneous manifestation, systemic manifestation. So now we have a patient which we suspect is having secondary syphilis. So let's say how we are going to diagnose it. In secondary syphilis, all serological tests are positive. So patient might not be having any clinical lesion, but this serological test will be positive. The sensitivity of these tests now approach 100%. So they are very sensitive in diagnosing the secondary stage. 1 to 2% of patients can have false negative result because of prozone phenomena. Now I'm not going into detail about the prozone phenomena. We'll discuss them in a separate lecture on diagnosis of syphilis, because that is a very complicated, somewhat of a confusing thing. So we'll try to discuss the diagnosis of syphilis in a separate video, and then I will discuss the prozone phenomena there. Let's move forward. Okay, so we have the patient with secondary syphilis, and now we're going to diagnose the case and be more sure about our differential. So this is the slide from last week's lecture on primary syphilis, and these are the areas that we have to take care while diagnosing syphilis. You can use direct identification, which is very important. You need to isolate and see the organism if it is present or not. You can use dark field microscopy, direct fluorescent antibody testing, PCR, biopsy to look and stain specifically for treponema, and electron microscopy. I'm not going to go into detail because all of this has been discussed last week in primary syphilis. We usually rely on serological testing. We have treponema-specific tests like TPHA and non-treponemal tests such as VDRL, RPR. Again, I'm not getting into detail regarding these tests because they were touched upon last week's lecture, and we'll discuss them when we'll be discussing diagnosis of syphilis. Okay. Point of care tests like multiplex PCR, SD Bioline, Syphic check are available. These have been discussed last week. In this lecture, we'll discuss mostly about the biopsy, histopathology appearance of secondary syphilitic rash. So let's move forward and discuss biopsy. The biopsy of the rash shows epidermal spongiosis, parakeratosis, and acanthosis. That means clinically this will show it as epidermal thickening. This will show as scaling, and this will show a bit of oozing. Okay, so the rash shows epidermal spongiosis, parakeratosis, acanthosis. It also shows leukocyte exocytosis. That means migration of leukocytes within the epidermis, so much so that it can mimic Monroe's abscess. So it mimics Monroe abscess. What do we mean by that? Micro-Monroe abscesses are the abscesses that we see in psoriasis. So it might look like psoriasis, especially if the lesion is very scaly. It might mimic psoriasis even on biopsy. Okay, so this kind of leukocyte exocytosis present. In dermis, we see angiogenesis, that means new blood vessel formation, blood vessel dilation and thickening, and endothelial swelling. So involvement of the blood vessels are also there. That's where the spirochetes are coming from. There is perivascular infiltrate, mostly composed of plasma cells, followed by lymphocytes and then histiocytes. Okay. In malignant syphilis, you will see an extensive feature of vasculitis and fibrinoid necrosis in the upper dermis. Remember, in malignant syphilis, you have a significant interaction or significant explosive wide form of immune reaction to spirochetes. Not exactly an immune reaction, but explosive presentation of syphilis because of increased spirochetemia. So that is happening, and that is why in biopsy you will see more features of vasculitis, fibrinoid necrosis. Remember the lesions individually. The lesions have a well-defined ulcer with significant perilesional erythema. So that is present. Okay, let's move forward. So this is a histopathology of secondary syphilis. I will put this link to pathology.med.edu. Here you have the digital slides for secondary syphilis, so you can zoom out and look at the infiltrate. I will not be able to do that in a PPT format, but I encourage you to go to this site and look for yourself regarding the histopathology. Now okay, mention in comments what do you think is the site of this biopsy. Okay, so if you know the site, mention them. So we see significant epidermal thickening, but the point of contention is this: the lichenoid infiltrate in the upper dermis. There is significant edema, significant inflammation in the papillary dermis, but the inflammation can easily go down and extend in a pandermal fashion or involving the entire dermis. But the significant inflammation is around the perivascular region and the papillary dermal region. So here also we see the infiltrate occupying the upper dermal portion, the retipex, and we can even see some of the exocytosis happening here. Okay, this is just a scanner view, so we won't be able to appreciate much. Now, this is some of the features, some of the photos that I've taken from this article. It's mentioned in the description. Go and read if you want to know about the biopsy features of syphilis. Okay, so we see a predominantly plasma cell infiltrate. So you have a plasma cell infiltrate mostly in the upper dermal area, but can easily involve the entire dermis. So here also, and these arrows, if you can look at these arrows, they are showing the vessels which are dilated. So here's a dilated vessel, dilated vessel, dilated vessel. Okay, this is also dilated vessel. Again, dilated vessels. So you have dilated upper dermal vessels with significant endothelial swelling and perivascular infiltrate consisting majorly of plasma cells, lymphocytes. So these are the histological features. Okay, in C. Lata, I think this slide is from C. Lata, in which you have thickened retipex which are elongated. Okay, so presence of elongated retipex, vessel dilatation, neutrophilic exocytosis, leukocytic exocytosis, the lesion on histopathology can mimic psoriasis. Okay, so remember that we have to have a good CPC, clinico-pathological correlation, to diagnose it on biopsy. These are further slide. Again, the epidermal, you can see the epidermal, sorry, not epidermal, upper dermal infiltrate in a somewhat of a band-like, but you also have perivascular involvement. So these are all perivascular involvement. Okay, you can see somewhat of a dilated vessel, and there is a certain amount of papillary dermal edema also present. Okay, now these are necrotic. This is a necrotic keratinocyte right here, if you are able to appreciate, and there can be coilocytic changes. So coilocytes can be seen, usually seen in warts, but coilocytes can also be seen. Okay. If you look at this, these are the neutrophils in the stratum corneum, which mimic Monroe abscess, but they are technically not Monroe abscess. So let's remove this term. So this is just neutrophilic exocytosis in the crusted lesions of syphilis. Okay, so we have discussed biopsy of secondary syphilis. Now we'll discuss the treatment part, which is actually easier. Remember, in secondary syphilis, the spirochetes divide very slowly. In primary syphilis, the division time is roughly about 30 to 33 hours, but it is significantly increased in secondary syphilis. So you need to repeat the treatment doses. In the early latent phase, the treatment is penicillin, 1.2 million units in each buttocks, intramuscular single dose. If it is late latent syphilis, then the treatment is benzathine penicillin, 1.2 million units in each buttocks every week for 3 weeks. So you have to give 3 doses 1 week apart. These two are the recommended CDC regimen. This is recommended CDC regimen. But remember that the CDC always says that if you cannot give penicillin, it's better to acquire penicillin and give penicillin. If the patient is sensitive or have an allergy to penicillin, you desensitize and then give penicillin. To know more about desensitization, look at the video of last week, primary syphilis, in which we discussed penicillin reaction, Alzheimer reactions in detail. So you go and look at that video and you'll be able to understand better. The alternative regimens include doxycycline 100 mg twice a day for 28 days. It has better CNS penetration, but it is contraindicated in pregnancy. In pregnancy, you can use erythromycin-based 500 mg QID for 28 days. It's an oral drug and can be used in HIV and pregnancy. So the recommended regimen is penicillin, 1 shot if it is early, and 3 shots 1 week apart if it is late. The alternative regimens is doxycycline 100 mg twice a day for 28 days, or erythromycin based 500 mg QID for 28 days. Now repeat after me. Benzathine penicillin 1.2 million units each buttock single shot early syphilis. Benzathine penicillin 1.2 million units in each buttock single shot 1 week repeated 2 more times. Alternative regimens doxycycline 100 mg twice a day for 28 days. Erythromycin based 500 mg QID for 28 days. Clear? Let's move forward. In the NACO regimen, the regimen remains same. It is the kit 3 white or the kit 4 blue. Kit 3 has penicillin and azithromycin additionally, and kit 4 has doxycycline and azithromycin additionally. The only difference or the change is that the duration changes, because these kits are the treatment for primary syphilis. Technically, cases of secondary syphilis should be evaluated further at a secondary care center, while these kits were formulated to be used in fields. That is why they have a simpler treatment regimen for primary syphilis. But what you can do is to provide additional kits so that the doxycycline covers at least 4 weeks. Okay, doxycycline covers 4 weeks, or benzathine penicillin 3 injections. So you have to use 3 kits if you are treating secondary syphilis using only the kit method. Okay. Follow-up is important. You have to do the cures test to see if there are decreasing titers. If the titers have decreased by 4 times from the initial titer, that and we're talking about VDRL titers, TPHA will unfortunately remain positive. So there has to be 4 times decline in titer, but some patients might not achieve. You have to look at presence of retropositivity or any other causes of immunodeficiency, which is running in the background, or else you will have a lot of relapses or the transmission to tertiary stage, which is very destructive stage of syphilis. You have to look at all the reports, viral markers which you had sent at the primary visit, address all patient concerns, make sure they have received 3 doses of penicillin, and remember the adage that when in doubt, treat syphilis. Okay, so you remember if the patient has received penicillin, and make a good documentation, make a good note of it that you have given 3 shots of penicillin 1 week apart under supervision. Okay, and address any issues related to partner, manage any partners who might be having any complaints, and even give them presumptive treatment. Now, this slide is again from last week's lecture on primary syphilis. These are the partner treatment recommendation as per CDC 2021. If there's exposure within the last 90 days plus duration of the ulcer, and ulcer means primary syphilitic ulcer, you have to treat them presumptively. Presumptive treatment is doxycycline 100 milligram twice a day for a week, or at least 2 weeks. If the exposure is between more than 90 days plus duration, you test them. If tests are positive, treat as stage. If test is negative, then no treatment is required. If test is not available or the follow-up is uncertain, treat. Again, if you're in doubt, treat. In high endemic areas, partners of patients who have high non-treponemal titers, that is more than 1:32, should receive a presumptive treatment. That means if I'm treating a patient who has titers more than 1:32 and I'm living or the patient is staying in an area which is highly endemic for syphilis, treat the partners as presumptive patient of syphilis, okay, irrespective of the test done or not. Okay, so with that, finally, we stop at this point. We have discussed secondary syphilis in much detail. These are some reading recommendations, chapter 36 from this book, CDC guidelines, NACO guidelines. This is just a short introduction for secondary syphilis. If you want to know about pathogenesis of syphilis, this article is very good. And this article will tell you about the histological features of secondary syphilis. And this is the URL for digital slides. So if you want to look at digital slide, zoom in, zoom out, and look at the histopathology of syphilis, go to this URL and they have availability of secondary syphilis rash slides. Okay, so with that, I'll finish the lecture here. So this would be our last lecture this year in the year of 2023. The next lecture would be on tertiary syphilis, and I would take a minute just to congratulate every one of you and wish you all a happy and prosperous new year 24. I hope this year would be better than this coming year would be better than the year that has gone, and all well wishes from my side. Although I personally believe that only calendar changes, everything remains same. But on a less pessimistic view, Happy New Year 2024. We shall meet next week with a discussion on tertiary syphilis. So we have completed our discussion of primary. I would encourage you to first see the video on primary syphilis in detail, then come back and see the video on secondary syphilis, because it is a story. It starts from a genital ulcer and gradually extends to involve all part of the body. That's the story of syphilis. That is why I say syphilis is leprosy of the STI world. Okay, and the detail in which we study leprosy is totally different from the detail that we study syphilis in. We have a conception in our mind that syphilis is a genital ulcer, but syphilis is actually a pan-systemic disease. So we must be very careful while keeping differentials in our mind, and we should keep our mind open to syphilis and its differentials. So with that, I will not take much time on New Year Eve weekend. Thank you. Any comments are always welcome. Doubt suggestions are welcome. And we'll meet you next year. Till then, Happy New Year. Adios. Bye bye. Enjoy your New Year parties. Make sure you enjoy them carefully and without any harm. Bye bye.